Hello, today I'm going to talk about what can go wrong with the lung. So first, I need to talk about what is going right with the lung. These four terms here are pretty key to understanding what's going on with the spirometer. Ventilation is air breathed through the mouth or nose and down to the alveoli where gas exchange occurs, whereas perfusion is blood flow, or when deoxygenated blood passes through pulmonary arteries to capillaries where nutrient and oxygen exchange take place. And that's often abbreviated as V over Q, ventilation over perfusion. And obviously, when there are diseases or when there's something wrong, one of these is likely to change. However, there's always going to be a certain amount of mismatch. So if you have a little bit, that's probably normal, but it's only when it becomes excessive. That's when you have to watch out for some kind of diseases. Next is the anatomical and physiological dead space. As it says here, anatomical is obstruction of airways, whereas physiological is normal structures but still some mismatch. So what this is talking about is that I think of it as anatomical as more of a physical reason. So maybe you swallow something, or maybe you have some kind of a pulmonary embolus. It's clogging a blood vessel here, or maybe you inhaled some food at dinner and it's blocking your trachea. So that could be that. Whereas physiological dead space is more like you have shunting of blood away. So you are still sending air in, you're ventilating, but the blood supply is not getting to that area. So the air is going down, but there's no exchange occurring. And that's where that physiological dead space would be. It's bringing blood to an area where it can't pick up or extract oxygen. And going back to this V over Q ratio, if you have a low ratio, you're going to have chronic bronchitis, asthma, pulmonary edema, whereas for increase V over Q, you'll have pulmonary embolism. So that's where it's clogging a blood vessel. The perfusion is going to decrease. Emphysema is also going to increase this ratio, but that's because it's going to be increasing the ventilation, because you're going to try and increase ventilation because your surface area is decreasing. But we'll talk more about that later. One last thing I want to mention is that the healthy lung has little alveolar dead space. And what that means is that there's a little bit of difference between the alveolar PO2 and then the arteriolar PO2, so the pressure of oxygen in the alveoli versus the arteries around it. Although there's a little bit of difference to allow for airflow, they never fully equilibrate because of the ventilation perfusion mismatch. Then how do you measure a normal lung? Well, you're basically going to tell someone to breathe and then measure how they breathe in and out. That is spirometry. So you see this guy here, he's blowing into this long tube, doop doop it up, and measuring. This is not how it looks like in modern times, but it's how they did it back in the olden days. And the important thing is that this is how they measure the changes. First thing you want to look at is this tidal volume here. This is when you're normally breathing, you're going in and out, and like it says here, it's a tide, so up and down, pretty normal breaths. When you're taking a deeper breath, that's the inspiratory reserve volume here, so you're going all the way up to 6, and then when you go, you're going back to tidal volume. But if you go that, and you keep going, you keep blowing air out, you're going all the way down to when you cannot possibly blow out any more air. That's the expiratory reserve volume. You're expiring the reserve volume that you have left. What you can expire is this residual volume right here. That's the RV. So this is the amount of air that's going to remain in your lungs no matter what. And that's going to keep them safe so that they don't collapse on you. So as you can imagine, some of these can be directly measured, and these are the volumes, but the rest have to be calculated, and these are the capacities. So you'll see that functional reserve capacity, since this includes the residual volume, we have to kind of figure this out by adding things together and subtracting. Same thing with the inspiratory capacity and the vital capacity. So you just use some simple math there and then calculate it out. And I won't do the equations because you can kind of figure out what you're adding together, what you're subtracting. So for instance, functional reserve capacity is just ERV plus RV, whereas total lung capacity, so that's everything, is just IRV plus TV, tidal volume, plus ERV, expiratory reserve volume, plus RV, that's residual volume. So that's everything here, total lung capacity. So how are you going to measure if there's something going wrong with a person? Well, you're going to ask them to expire as much as they possibly can in 1 second, and that's going to give you the FEV1 over FVC here. And that is the functional expiratory volume in 1 second over the functional vital capacity. So, like I said here, it's just giving you a ratio of how much you can get out. Like it says right here, exhales as much air as fast as possible. And how fast you can do that can tell you if there's actually something wrong with the lungs. For example, for restrictive lung diseases like fibrosis, you're going to see a decrease. And maybe you know why, maybe not. We're going to talk a little bit about why later. Whereas for people with obstructive lung diseases, you're probably not going to see much of a change because both of these numbers, top and bottom, are going to be changing. This graph should be relatively intuitive for you. Even if you don't really understand what compliance is, you can connect it hopefully with the diseases that are associated with changes in compliance. Remember that this is a normal lung, and this is going to vary inversely with elastic recoil. So if you have a high compliance, you're going to have low elastic recoil, whereas the inverse is also true. If you have decreased compliance, you're going to have stiffness, right? So if you have fibrosis, that's like having a belt around your chest. The lungs are not going to be able to expand or contract as easily. Breathing is going to be restricted because of that. And like it says here, high surface tension. So it's really hard to physically expand and contract. You're having trouble with that. But the airways themselves are actually fine. They're healthy. Whereas in contrast, obstructive diseases, an example here is emphysema, you can think of it as breathing through a straw. And that's where you have something blocking flow at some point. Asthma, chronic bronchitis, emphysema, and in the case of emphysema, you're going to have floppy lungs. So any smokers out there, you're going to have a decrease. It's slowly degrading the lung tissue, all that smoking, and it's going to create a floppy lung. So whereas you have increased compliance, the lung can expand just fine. It's super easy to expand the lung. And you think that's really easy, right? You want to have relative easiness expanding the lung, but the problem is that you cannot contract them because, like I said before, if you have increased compliance, then you're going to have low elastic recoil. So whereas the lungs can expand easily, they're not going to be able to bring them back as much. So once they're outward expanded, then they're going to kind of stay outward expanded, which is why you have people with the emphysema disease struggling to then exhale. And over here, going back to the spirometer record, you can see some of these ratios and how they're changing, how they're decreasing. So restrictive, remember this is fibrosis here, all of them are decreasing. Whereas for obstructive diseases, you'll see that the residual volume is actually increasing. And that's what I was talking about here, where once you're expanding the lungs with that increased compliance, it's easy, but then you're going to have a real hard time exhaling all that air that you took in. So this is a lot bigger than what you have for the normal lungs. And that's partly why for restrictive diseases, you're going to have this decrease in the FEV1 over FVC ratio. The normal is 80%. But for obstructive, you're not going to be able to tell as much based on this ratio if there's a disease. There are three main factors that are affecting resistance in the lung. The first is lateral traction or mechanical tethering. That's what you can see up here. Second is surfactant, which I'll talk about right here. And then the third is transpulmonary pressure, which is right here. So in the lungs, the alveoli have problems. You'll see that this one is larger and this one is smaller. So based on some laws of physics, you might have learned these, but because of the increased pressure in here, if you are equilibrating these two alveoli, this one's actually going to collapse unless you have something preventing that. And that is going to be surfactant, which minimizes this collapse by lowering surface tension here. So you can read what these words are saying here. I'm not going to just read them off. The other thing is that the alveoli are tethered to adjacent ones. So even though there's only two here, in reality there's a bunch more hanging out. And these are kept open by the principle of interdependence. So they're all tethered all together to kind of create this network of alveoli holding each other together. Now you might have seen this law called the law of Laplace, or Laplace, I'm not really sure how to pronounce it, but that's just pressure equals 2 times the tension over the radius. And so that's saying that as the radius of an alveoli or something gets smaller, the tension is going to increase here. So that's just where I was talking about the alveoli tending to collapse. As they're getting smaller, they're more tending to collapse. And you have the flow of air from smaller chambers into larger ones like this. Luckily, the surfactant prevents this. So, how does surfactant work? Well, it's pretty much like a detergent, and you can read these boxes along with me, but they have their hydrophilic heads here interacting with the water, and then they have their hydrophobic tails going outwards like this. And what this does is that this prevents the surface tension that would normally be present in alveoli. So it's pushing outward like this as these molecules are pushing like that. So it's making it easier to pull things apart. So if you've ever had slides, it's like working with a microscope, putting two slides together, you'll notice that it's really hard to pull those two slides apart just with your bare hands because of that really high surface tension. So with this surfactant here, this prevents that happening. It's easier to move apart. And you'll see here that detergent molecules orient themselves so that their hydrophilic heads point towards and interact with the most superficial water molecules, whereas the hydrophobic tails, right here, point towards the air. The hydrophilic surfactant heads pull strongly upward on the most superficial water molecules, greatly reducing the net force on the surface water molecules and minimizing their tendency to dive into the bulk water. So overall, the name of the game is that since these are reducing surface tension, it's easier for the alveoli to expand and contract, and it also prevents the smaller alveoli from collapsing. Now going back up to the lateral traction and transpulmonary pressure, remember that I talked about how all these other alveoli are together and kind of this meshwork here? Well, for lateral traction, that's kind of what it's talking about here. So all these alveoli, they're not working separately to expand or contract, they're kind of working as a unit. So alveoli next to each other can help each other move, and it's kind of like when your neighbor helps you move from one house to the next. It's harder for yourself to do it, but when you have a neighbor, then it's going to help that along. Whereas for transpulmonary pressure, the transpulmonary pressure acts outward on airway walls and therefore increases their diameter. And this is especially true during inspiration. So remember, it's easier to inspire than to expire, because as you're inspiring, you have resistance decreasing because you're increasing the radius, and you also have a decrease in pressure. Whereas for expiration, it's the opposite. So you see the alveoli is getting smaller, and you're kind of going against this resistance and pressure gradient. Okay, now that we have all three of these things together, one major thing that can go wrong is with surfactant. So type 2 alveolar cells are going to be secreting surfactant in the lungs here in the alveoli. But if you are born prematurely, or if you just don't have these cells developed yet when you're born, that's what's called infant respiratory distress syndrome. Infants have a really hard time breathing because they just don't have enough surfactant to reduce the surface tension. So each breath they take is with a lot of energy, and it just tires them out. And that's not good. Okay, now that we have hopefully a good understanding of all this stuff over here, we're going to head back to our diseases. And we're going to start first with the restrictive. So that's going to be the pulmonary fibrosis. That's this box right here. There's this guy. Now, as it kind of says in these pictures here, fibrosis is a disease where there is deposition of fibrous tissue. So the lung is getting stiffer and more difficult to inflate, which is decreased compliance, right? They're not as compliant to moving in and out. And also, since you have this deposition of extra tissue, you're also going to have a diffusion barrier. So it's going to get harder for things to move across the capillary wall, and then also for your lungs to expand and contract. So the same transpulmonary pressure that produces a 500 milliliter increase in volume in normal lungs produces a lot smaller of that same volume increase in fibrotic lungs. So again, the compliance is a lot less, and the elastic recoil is greater, so they're more prone to pull back in than normal lungs. Now we're going to talk about COPD, which is those chronic obstructive pulmonary diseases. On the top here is emphysema, and you can kind of include chronic bronchitis with this, and then on the bottom here is asthma. So for chronic bronchitis, that's long-standing inflammation of the bronchi or bronchioles. Remember it's chronic and not just bronchitis. whereas emphysema is destruction of alveolar walls, producing a smaller number of large alveoli. And it's good to remember that if you see chronic bronchitis, you'll likely also see emphysema. And emphysema is a consequence usually of cigarette smoking, where you're going to have a lot of loss of pulmonary tissue, and you're going to have, like it says over here, floppy lungs. So since you're having this loss of tissue, they're going to become more compliant and a lot easier to expand. Since the lungs are easier to expand but not contract, you're going to see these people with barrel chests around, and that's from that increase in compliance. So because, like I mentioned earlier, that it requires work to inflate the lungs against their elastic recoil, you might think that a little bit of emphysema might be a good thing. You know, everyone wants a little bit of emphysema, can breathe more easily, but that's not true, because while the emphysema people can exert less effort to inflate their lungs, these people also have difficulty expiring those same lungs, because the destruction of all this architecture inside the lungs also makes it difficult to keep the airways open when they're expiring. So they're more likely to actually collapse completely, which then increases the airway resistance a lot. So with the destruction of alveolar walls, emphysema increases the static compliance, which by itself would make it easier to inflate. However, the destruction of parenchyma also reduces the mechanical tethering / lateral traction of conducting airways. Remember, that's where we talked about this lateral traction, so that's decreased, and that leads to an exaggerated collapse of the airways during expiration, and thus to increase in airway resistance like I just mentioned. So hopefully by repeating that 2 to 3 times, that's starting to make a little bit of sense. So how do people with emphysema get around this? Well, one way is that they exhale slowly. So during expiration, if they do that, it translates to a less positive alveolar pressure and thus a less positive intrapleural pressure, which minimizes the tendency for the airways to collapse. Second is that they breathe at a higher volume. So at a higher volume, that maximizes the mechanical tethering that I talked about up here, the lateral traction, and opposes airway collapse during expiration and thus minimizes the resistance at the alveolar wall. Finally, they're going to exhale through pursed lips. So that's also known as puffing. You might have seen people do it, and it just makes an artificial high pressure up at the level of the lips. So that just means that the lips now are having a greater share of the pressure drop, which means that the airways that don't have any cartilage are less prone to collapse when they're exhaling. Finally, we're going to talk a little bit about asthma here. This is where the person's airways become inflamed, narrow and swell, and produce extra mucus, which makes it difficult to breathe. You're going to have, like you imagine here from these pictures, an increase in airway resistance, increase in residual volume, and of course more difficult to breathe because these airways are narrowing. And so in general, that's going to cause alveolar PO2, pressure of oxygen, to decrease, as well as arteriolar pressure of oxygen to decrease. So you're not getting as much air into the lungs, and you're also getting not as much perfusion into the capillaries. So no bueno. If you look at this graph here, we have on the x-axis percent of capillary length, and then on the y-axis pulmonary capillary PO2. Looking up at here, 100 is kind of the pressure we're working with. So you see this matches up to 100 here, so this is about 100% of gas exchange, or almost complete gas exchange. And looking at a normal lung, that's going to happen at maybe 40% of the capillary length. So as soon as you get down to 40% in a normal lung, or maybe 30%, you're getting full gas exchange. However, in a diseased lung, that's going to take longer. So maybe, well, I guess never. It's never going to get up to that point. So that's what we're talking about with the obstructive diseases, pretty much, is that since you're getting this decrease in tissue or even narrowing of the airways and all this mucus in here, that's preventing normal gas exchange. So you're just not getting as much oxygen to the tissues as you would with normal lungs. Finally, we have this table that you can pause and take a few seconds to look at and just run your way through, and hopefully you'll understand how each of these work. I'm not going to read through every single one because that's silly, but that is for you to check out.